Hi, welcome everybody to the August Virtual Knowledge Group call. This call is specific for the state flex programs, and so we are excited that you're here to talk today about the forthcoming Rural Emergency Hospital or REH model. So we have a group of panelists that I'll introduce to you in a minute, and this call is being recorded. The recording is going to be placed in the Flex Program Forum. So a reminder that that is a place where there's access for the state flex programs for the information, but it won't be a webinar that you'll be able to share out to those that are not flex program participants. So if you're looking for further information about the REH model or things that are shared today, let us know, and we might be able to distribute slide sets or things like that to help you out. This is certainly a topic that all state flex programs need to be building awareness of, and we hope that by the end of this virtual knowledge group call today that you'll be able to explain the development of the REH model and its legislation, that you'll be able to identify how the critical access hospital and the REH model can be considered for rural communities. It's definitely not going to be a fit for everywhere, but what are the things that we can do to kind of help consider if this is a viable option? We hope that you'll be able to recognize how the REH technical assistance funding will be facilitated. We definitely want you to have an opportunity to ask questions. Today's virtual knowledge group call is a little bit longer than our normal 60 minutes. It's going to be for 75 minutes, and that's really, we do want to facilitate that conversation later on today. So when we get to that point of the event today, we do encourage you then to turn on your cameras, raise your hand, ask a question, type it in the chat box, or simply unmute as well too. Patricia has some polling questions that we'd like to ask of you about your level of knowledge about the Rural Emergency Hospital model. So we have 2 questions, and Patricia, if you could post those now, that would be great. So the first question is concerning your knowledge about the Rural Emergency Hospital model. Are you extremely confident all the way down to unfamiliar, which is totally fine as well? And then the second question is concerning your knowledge about initiatives that could be implemented by your state to support rural hospitals considering this model. Are you extremely confident, again, to unfamiliar? We'll ask those similar questions at the end of the virtual knowledge group. It's a way for us to evaluate the success of the event and if we were able to communicate information that's important and helpful to you. So please stick around to the end, and we would like you to answer those questions at the end of the event today. So with that, I'm going to introduce the 4 presenters that we have all at one shot here, and then I'll turn things over to the first presenter. So joining us today is Dr. George Pink, and he teaches courses in healthcare finance and is involved in several research projects that are funded by the Federal Office of Rural Health Policy. And George is a member of the University of North Carolina, Chapel Hill, partner of the Flex Monitoring Team and the Rural Health Research Center there. Prior to receiving his PhD in corporate finance, he spent 10 years in health services management, planning, and consulting. As a consultant, he directed or participated in planning projects for 10 small rural hospitals. And over the past 30 years, he's served on over 100 boards and committees of hospitals and other healthcare organizations. He's written more than 80 peer-reviewed articles and has more than 250 presentations in 10 countries. George is a member of the board of Piedmont Health Services, a large community health center that provides primary health care to residents of 5 largely rural counties in North Carolina. Joining George in the following presentation is Pat Scow. Pat's the executive director for the Illinois Critical Access Hospital Network, or ICANN. And there, Pat has the overall accountability responsibility for the organization and subsidiaries. She's also responsible for the Accountable Care Organization, or the Illinois Rural Community Care Organization that they run there. And she represents the organization and its members, serving as the chief officer. Pat is a seasoned representative of the state flex programs, and she's the director of the Illinois Flex program, working in alignment with the Illinois State Office of Rural Health. And then we have 2 presenters that are joining us from the Federal Office of Rural Health Policy and the Health Resources and Services Administration, who I think are familiar to most of you, if not all. And that's Christy Martinson, who is the Hospital State Division Director, and Laura Seifert, who is a program analyst there and is the National Flex Program Coordinator. So they'll be presenting to us at the end about what's the expectations of the state flex programs regarding the REH model. So with that, I will turn things over to George to get us started.
Thank you, Tracy. Hopefully everybody can see my slides.
Yeah, that's great.
Great, thank you very much. It's always risky putting an academic as the first speaker because they tend to be windbags, but I promise to be brief and turn the presentation over to Pat and my other colleagues as soon as possible. So my job is to review the basic constructs of the Rural Emergency Hospital, where it's come from, and I'm going to go through some of the proposed conditions of participation, which literally only came out in the last 2 weeks. So why is this new model coming about? Essentially, there's 3 sort of secular trends which I think have driven a lot of this. First of all, the rural hospital closures. There's been 140 closures since 2010. This model is aimed specifically at communities at imminent risk or likely risk of closure of the facility. The model is not aimed at communities which have got a vital, thriving rural hospital. It really is aimed at communities where the hospital is in very real risk of losing the inpatient facility and the facility as a whole. Secondly, we've seen a significant decline in inpatient use. We're writing another study right now where we're looking at small rural hospitals and their emergency department volumes, and there's over 300 hospitals in our country which are seeing fewer than 6 patients a day, 6 ED patients per day. And so there's a lot of inpatient capacity which used to be used, which is no longer being used. And instead, they're now larger outpatient facilities. And then finally, access to emergency care. There is what we hear over and over again in communities where the rural hospital is closed is the service that the community misses the most is the emergency department. So where did the REH come from? There's a lot of speculation about, but I think most people agree that it came from the legislation that Senator Grassley introduced in June of 2015, I believe it was. It's gone through several transitions since then, but basically it proposes a new type of provider. And you're going to hear me say that over and over again. This is a new type of provider. It is not a critical access hospital that doesn't provide inpatient care anymore. It is a new type of provider that provides ED care only, observation care, and outpatient services. There are no inpatient services at all. There are no swing beds. It's entirely an outpatient ED facility. EMTALA will apply, and critical access hospitals, any critical access hospital and any PPS hospital with 50 or fewer beds can apply. The proposed conditions of participation for REH, they came out on July 6th, they're issued, and the comments are due at the end of this month. I'm going to quickly go through them to give you an idea of what these beasts will look like. The staffing, of course, is the major component of the cost of any kind of healthcare organization, and that's no different for an REH. The proposed staffing includes nurse practitioners, physician assistants, and clinical nurse specialists. Some of the NPs and the PAs may be granted medical staff privileges. They have to have adequate personnel to meet emergency care. CMS is currently seeking commentary on whether a practitioner has to be on site all the time, or whether an RN can be there and then call in the practitioners as necessary. But there has to be a physician, a PA, an NP, or clinical nurse and specialist with training in emergency care available by phone within a specified time frame. This emergency department has to be staffed 24 hours a day. Again, it's still being debated as to who has to be there, but there has to be somebody there 24 hours a day. The emergency service will be organized under the direction of the medical staff, integrated with other departments, and it must meet all the regulations required of a regular hospital emergency department. There are a list of required services. I'm going to go over only 3 of them here, but these are probably the most salient ones. Lab services, there's got to be lab services available 24/7. Again, the CMS is recommending additional lab test capability in addition to the basic services. Imaging, standard imaging requirements for an ED, including a CT scanner. Pharmacy has to be operated with a pharmacist and dispensed by a physician or a pharmacist. Transfers and referrals will be among the probably more interesting requirements. They must have an transfer agreement with a certain level 1 or level 2 trauma center for referral transfer patients. A lot of people have criticized this and said, well, what's wrong with a 3 or 4? The conditions of participation do not preclude agreements with level 3 and 4, but they still have to have a level 1 and level 2 trauma center for referral. And it's okay if it's in a different state. Probably, again, I'm a finance professor, so I'm putting my biases up front, but in my opinion, the model will more likely proceed and have more take up if the financial incentives, if the business case is there for the model. These were filed last week on July 26th. Commentary is due by middle of September. Again, I'm not going to go over there's like 30, 40 pages of detail in the proposed payment policies on how these numbers came by. The only number that you need to look at here is the 268,294. That is the proposed monthly additional facility payment. What is that amount? Essentially, it is a standard amount that every single REH will receive per month to pay for the fixed overhead, the costs of maintaining the rural emergency hospital. It does not, well, I'll talk about more of that in a second, but that's where the 268 came from. That's the most important number. That is the number that's getting a lot of attention by hospitals. In terms of other types of payment, there is one, so that's one source of funding for the REH. The second source is the enhanced OPPS reimbursement. So if a service is paid for under using the OPPS schedule, the REH will receive the OPPS payment plus 5% for that service. So it's augmented OPPS payment. Other services, outpatient services that are not paid under OPPS will be paid under the fee schedule. The co-payment, SNF, the ambulance, the rural health clinic are all the same as currently as they are paid now. There's no difference. So there's really only two components to the payment of this REH: the monthly additional facility payment and the enhanced OPPS payment. So you can see, except for the monthly additional facility payment, this is really a PPS model, which again is really important to abandon your thoughts of cost-based reimbursement that we all know and love for critical access hospitals, and focus on the fact that this really is a new provider type. The facility payment will increase each year by the same percentage increase as the hospital market basket. One source of controversy is each REH receives the same monthly amount. Doesn't matter how many patients they see, doesn't matter whether they're serving high needs areas or a population with high unemployment, high care needs. Everybody gets the same amount per month. REH, I've already mentioned that, and off-campus provider based departments also get the 5% OPPS payment. Two open questions. I mean, there are many payment questions, but two of the biggest, in my opinion, are we do not know how state Medicaid programs are going to pay for REH services. Are they just going to use the historical method that they've always used for CEHs, or are they going to come up with some other mechanism that will also require states to license these facilities? So there's a lot of uncertainty at the state level. It's going to be state by state, obviously. And secondly, there's no mention of capital in the legislation. What is clear from talking to a lot of consultants and people who've got experience in running freestanding emergency departments is, again, this is a new provider type. It's not obvious. In fact, it's obvious in some cases that existing hospital buildings and plant will not be suitable for REHs. Many are going to have to be built from the ground up with new physical plants, much smaller, fewer staff, outpatient only oriented. So in summary, rural hospital closure are a problem. There are 140 since 2010. Patients are traveling a lot further because of the closures. Closures took a hiatus in 2020, 21 because of COVID funding. A lot of us believe that those numbers are going to start going up again. So how are we going to address this? The rural emergency hospital may be a solution to some communities that face imminent risk of closure. I think what's clear is that their current models are not working in those communities. And again, legislative action by states will be required. So to conclude, CMS, I think, is making a good faith effort to make sure the regulations and guidance facilitate adoption, and that this model really will work in rural communities. And to be the optimist in me says it could be an important step for some communities in preserving emergency outpatient service access, particularly in communities where I've got very small emergency departments and then where the facility faces risk of closure. However, there's always a but, and academics are really good at identifying the buts. The but is three concerns that I've heard. One, large systems may replace affiliated rural hospitals by REHs, not particularly because it's good for the community, but rather to save money or to reduce losses. Secondly, we've heard of some interest from venture capital firms that may see REHs primarily as an investment vehicle versus a way to meet community need. And finally, there's a lot of criticism of the current act that may require legislative undoing. And for example, facilities that are already closed before 12/2020 cannot apply for REHs. They got to be an open and functioning hospital after December 2020, which is when the legislation was passed. Swing beds are not allowed. Again, this is a huge concern that's been raised by NRHA and others. And then similarly, participation in 30/40P program is not allowed as well. Again, that is often the difference between a negative margin and a positive margin for many rural hospitals. So there's still some very big outstanding issues to be decided, but in general, I'm going to try and be optimistic. Thank you very much.
Thanks, George. Really appreciate it. So I think we should pause here for a minute or two and see if anyone has any particular questions about the model. Terry, I see your hand raised right away. So yeah, go ahead, Terry.
Thanks, Tracy. George, I was struck by your comment about the existing hospital structures not being relevant for this model. It strikes me that couldn't the bed, the area for beds actually be repurposed for outpatient services, a gym, et cetera? Could you talk a little bit more about that, please?
Yeah, and thank you, Terry. There is a mixture of opinion. Let me put it that way. Again, some of the folks I've talked to, ER docs that run these kinds of facilities, basically say the inpatient facility, the layout of them, where imaging and lab is in relation to the emergency department and so on, is just not the right model for this, is not the right physical layout for this kind of model. Now, other people say exactly what you say is, well, that provides them, maybe opportunity to expand outpatient services, expand access for community services that they haven't had the space for before. I think it's going to be a community by community, a facility by facility decision. And some facilities are so old, they won't lend themselves to this new model as well, the technology that's required and so on. So I'm not going to make it say everybody's going to have to get a new building. But on the other hand, I think we'd be naive to say that, oh, you can just renovate your current building. That's not going to be possible in some places.
Terrific, thanks. One more quick question, if I can, which really has to do with the volume itself. You said the lower volume hospitals would get exactly the same as the higher volume. It seems like for a state, a hospital in remote Montana, for example, that there might, again, if they're having financial difficulties, it might be more advantageous for them to go into this than let's say a larger hospital in Iowa where they may have a greater volume. Is that kind of what you're saying in that regard? That's interesting.
Yeah, I'm saying under the legislation, all REHs get the same monthly additional facility payment. They'll get different outpatient volume. They'll get different outpatient revenue because their volume will go up and down with the OPPS revenue, but everyone will get the same basic monthly additional facility payment.
Got it. Thank you very much, George.
Thanks, Terry. Great questions. Jennifer, I see your hand raised and I see some questions coming in the chat too, but go ahead, Jennifer.
Sure. My specific question right now, although I have lots, is about the definition of rule. Have we gotten any more specifics about, I'm thinking in particular, small PPSs who currently meet the FORHP definition of rule for, say, SHIP or some of those programs. Are we going to be able to capture them in this REH definition?
I don't know the answer to that, but I'm going to ask Laura or Christy if they know.
I think that might be a Christy question.
I'm not either.
I'm sorry, what'd you say, Christy?
I'm not sure the answer to that either.
Okay, well, I'll just put it out there is that we have a couple who really fit that very narrow circumstance, and we really need some clarity on that one.
Thanks for bringing that up, Jennifer.
Sure.
Okay, something we can follow up on. So a couple other questions from the chat. George, could you reshare the last slide that you had up and recap that one again, please?
Is this the slide,
Yes,
Tracy?
please. Yep.
You want to recap it?
Yeah, if you could just kind of explain it one more time, please.
Okay, so I think there are three concerns that I've heard mentioned. One is there's a concern that large systems, healthcare systems that own or operate small rural hospitals may see REH model as a way of reducing their losses or saving money by replacing the inpatient facility with an REH. It's just a cheaper way of staying in the community, but at a much lower cost. That's one concern I've had. The second concern I've had, and I've actually had emails from venture capital firms as well, interested in this model as an investment opportunity. I guess it depends on your attitude towards venture capital, but for many people, that's a concern. And then thirdly, under the current act, which is not, the three sub-bullet points there can't be changed by the conditions of participation. It will require legislative changes, because these three things are actually in the legislation. And that is that facilities that close before December 2020 are not eligible to convert to REH. So if your state, if there's a hospital in your state that closed in November of 2020, they're out of luck under the current legislation. Secondly, there are no swing beds. There are no inpatient beds at all. And so many rural communities absolutely depend on swing beds to meet local needs. Well, this model does not allow for swing beds. And third, participation in the 340B program is not allowed. At least, again, that's what the legislation says. If this was the change, it would require a legislative fix. Now, I'm hoping Sarah Young's going to correct me on all that.
Thanks, George, for doing that again. I appreciate it. So yes, so REHs can be part of a larger system or affiliated with other systems. A couple other questions. Do hospitals have to have been open in December 2020 or just after that date? In Oklahoma, they've received a few questions if a hospital can open as an REH.
Yeah, so right now there's no, again, I'm going to look to my FORHP colleagues to confirm what I'm saying. I do not think there is any provision in the act for a new facility that comes to start out of nowhere. You've got to be a hospital, operating as a hospital to qualify. If you closed after 12/20, if you closed in July of 2021, you are still eligible to apply for an REH. You had to be open after December 2020. You could not be closed before 12/20.
Okay. Thanks. Anything to add from FORHP, or does that all sound accurate to your understanding?
If you'd like me to jump in. Hi, everyone.
I would. I always want you to jump in, Sarah.
Sarah, great to see you.
Sarah, great to be back with Flex conversation this afternoon. To agree with everything George said. To maybe reframe it, restate it in different words. The way the legislation was written, a hospital had to have qualifying status on the day the legislation passed. So that was effectively December 27th, 2020. Pick a random and arbitrary date. And so a hospital had to be open on that date and have qualifying rural status on that date. A hospital that has since closed could potentially reopen as an REH, although the proposed rule does not provide any details on how that process might work. But a hospital that closed prior to that date didn't have qualifying status on that date. And then also to Jennifer's earlier question about hospitals with rural status, it can be sort of tricky and situational specific, especially some of those hospitals that are in edge case situations. My understanding on what's currently written in the proposed rule is that, again, kind of going back to the qualifying on the day the legislation passed, PPS hospitals had to be located in a rural place with rural status or have active rural status reclassification on the day the legislation passed. And the urban to rural reclassification rules for PPS hospitals are pretty complicated. So that's going to be a situational specific determination in each hospital case that may take some looking into.
Thanks, Sarah. I appreciate it. We all do.
And
go ahead.
one other plug, I would say, this is a proposed rule, and it's really important if you either like or do not like the proposals that CMS put forward, that rural stakeholders make public comments on what should be kept or what should be changed out of that proposal, because that's going to determine what ends up in the final rule, which we will all be implementing.
Okay. So a different question, do we have any information yet about relocation? Maybe this is a little bit farther down the train, but if a critical access hospital converts to REH and then they want to move in a few years, can they keep their REH status, or do we know anything about how that will work yet?
It's a great question. I think the proposal is silent on that issue, which would be a great topic to submit some public comments about, saying, please clarify, will the same relocation rules applied for cause be used for REHs, for example?
Okay, great, thanks. A couple more questions, and then we'll switch to FORHP sharing about the flex program role. Is there any possibility that an existing satellite emergency facility that grew out of the closure of a Medicare dependent SHIP hospital could convert to this REH model? It appears to be very similar in content, but has more enhanced reimbursement.
Wow, I think if I understand correctly, if it is not a freestanding hospital right now, if it's not licensed as a hospital, then it's not eligible to become an REH. But again, I'll ask Sarah to correct me if I'm wrong.
I think you're right. Yeah, Sarah's nodding too. It have to be a hospital status right now.
If it was a hospital on December 27th, 2020, has since converted to a freestanding ED and would have qualified on December 27th, 2020, it might be able to convert to an REH. But if it converted to a freestanding ED in 2019, no.
Okay, so that date's really key. Okay, great. Good questions, everybody. And then one more thing, some clarification about swing bed. Can you still have them if they're a freestanding unit, or just totally not allowed to have them?
Yeah. Okay, so there was a slide I did mention, there was a point on the slide, but I didn't talk about it. There is an option for a a SNF DPU to be, there's a skilled nursing facility DPU to be part of the REH. So that is a possibility. Now, when I've talked to, again, there's mixed opinion about this. When I've talked to a distinct part unit is DPU. When I've talked to people, the first question they ask is, well, why would you have a skilled nursing facility attached to an REH when that's 24-hour care? Why would you get rid of your acute inpatient beds but maintain 24-hour care for the skilled nursing facility? So the incentives to do that are not clear to many people.
Great, thank you. And Sarah Young's commented that a SNF, DPU, or a skilled nursing facility distinct parking unit would be paid at that skilled nursing facility rates under Medicare.
Yes, which is typically a lot less per day than cost-based reimbursement.
Right. Great, good questions. Well, thanks, George. Thanks, Sarah and FORHP folks for fielding those questions too, and great questions from everyone part of the call here. So I'm going to turn things over to FORHP and Christy and Laura there now, who are going to share some of the content about what are the plans for rolling this out and the state flex program involvement with that.
Great. Thank you, Tracy. And are you able to see my screen?
Yes, we can.
Yep.
So we also found out Pat's not able to make the call today. So I'll be sharing a couple of the slides that she had put together for the NRHA annual meeting presentation, just to kick things off before Laura and I get into our kind of TA updates. But I want to say thank you to George Pink for all the work he did and his team at UNC, kind of digging into all the REH data and understanding about REHs as soon as the program was established in the Consolidated Appropriations Act, because there's been so much work from on that research side, and then from the FORHP, Federal Office of Rural Health Policy, National Rural Health and Human Services Advisory Committee, kind of talking through what this model is, what recommendations from rural stakeholders would be to ensure this program can be successful. So that we had a lot of information that we could share with our CMS colleagues as they were putting together the rules. Now they have some of those proposed rules out. And as you can see, if you've looked at what the comments are, there's actually a lot of questions that they have rather than information that they're providing. Just because this is a new model, they want to make sure that it's successful as well. So with this call, we wanted to kind of give you an opportunity to understand a little bit more about rural emergency hospitals in case you haven't had the time to pay attention to it up until now. And then talk a little bit about what's coming in terms of technical assistance, knowing that there's not a lot of answers that we have right now, knowing that we don't know what it's going to look like and what some of the challenges will be, or, you know, be able to see what those successes are and share them as well. So it's fine to have a lot of questions. It's fine that we don't have answers. We have a plan to kind of work to get those answers better to you. So just wanted to kind of mention that before we get into the slides. So, you know, one of the things that, so Pat Scow is part of she's a member on the National Advisory Committee for Rural Health and Human Services. So she was a part of the committee discussing the rural emergency hospital model. And she and George presented at the National Rural Health Association meeting back in May. And I thought the slides were really good. So that's why I wanted to have them share them with you, because it's kind of a good 101 of, you know, what is a rural emergency hospital? Why did it come to be? And then what Pat talked about in her slides was, what are the questions that people should be asking? So these are not necessarily framed for the Flex program coordinator perspective, but more as a community thinking through, what is this model? What are the things that we should be thinking about? So, you know, first off, it's not one size fits all. As George mentioned, this isn't going to be a solution for everybody. Some people will know right off the bat, like if you have a lot of inpatient services that you're still providing, this doesn't make sense for you at all. Also, this is a new model. So even how it's structured might not have been structured in the best way. So, you know, now with the commenting period, it's good if we know things that we can comment on now, that's great. But there's also opportunities over time to kind of see how things are working or how they're not, and get feedback to the people who are kind of in charge of these programs. And And, you know, when the critical access hospital model was first rolled out, there were a lot of challenges too, and it took some time for people to see if it made sense in their communities or not and to convert. So lots of things to think about, and so many what ifs, even, you know, outside of does it make sense to convert to this new model or not, but all the other issues that a community and the hospital is already dealing with, like pandemic and natural disasters, kind of those daily things that take priority and impact what types of services are needed in a hospital, what type of staffing issues there might be. You know, for the payment model, understanding with the current financial systems within a hospital, is it enough? Is it something that will be sustainable within the community? George mentioned about for-profit systems and kind of their perspective coming in for these rural hospitals and the perspective that they might have about it or not. Looking at the quality and safety standards that are going to be coming out from CMS and seeing, you know, are they enough to ensure safety for the community? Thinking about how rural emergency medical services will fit into the new model, the new rural emergency hospital model. Thinking about recruitment and retention of staff and switching to the new model. How things might shift in terms of emergency department care, and, you know, how does it work in the real world? So for the community, you know, how much of the hospital business really has moved toward that outpatient model? Is the emergency department kind of the main access point for care, moving away from inpatient services? Is there, you know, what's the workforce like? You'll still need staffing within the rural emergency hospital model. So will you be able to get the right staff if you move into the new model? Looking at kind of the financial system, the financial situation and position of all the service lines within the hospital to understand what that would look like under the new payment structure. And then what are the health needs of the community? Making sure that, you know, making the shift to the new model is still going to be able to best serve the community health needs. So kind of taking time to start having those conversations. Change is always hard. And so it's kind of being open to talking about it without having to just decide right away that you're going to go that route or not. Kind of helping, you know, from the flex programs, I think helping communities understand what are the questions that they should be asking, see what opportunities there might be. This new model was created because of the wave of closures that rural hospitals have been facing. So this is a great solution for some. So understanding it could be a great solution for a community where the current CH or PPS model is just not working. Conducting financial analyses, doing that community health needs assessment to understand what those community needs are to better make an informed decision. Talking with medical providers, of course, that's something it's kind of impacting all of the staff moving to a new model. So making sure that you're engaging with people who will be impacted. Looking at strategic plans and financial security going forward. Tapping into the outside technical assistance, and we're excited to talk about the funding that we got in our office to support that TA. And then, as we talked about before, like continuing to share how the model can be improved. So for those communities that decide to move forward with this, they'll be really knowledgeable about what works about the model. So now to get into what is the technical assistance for this model. So we were really excited to receive funding through the Appropriations Act in 2022 to support technical assistance, knowing there's just so much involved in shifting to the new model and having support available to communities who are going through that process of determining if it makes sense for them and then going through the conversion process. There's just a lot of questions that they'll have and support that will help them move successfully into the new model. So here's just a couple of the language that identifies the $5 million for the REH TA program within our FORHP appropriations this past year. So we determined to kind of divide up the funding to support a three-pronged approach for TA. And all of this knowing, you know, there's so many unknowns. We received the funding in March of 2022. CMS still hadn't put out any rules specific to what the REH model would look like in practice. Not knowing, you know, how much interest there would be in communities. So kind of thinking, okay, for year one, what makes sense to, with all these unknowns, make sure that hospitals know about the program and have support to think about conversion to this model. So this three-pronged approach is creating the National Technical Assistance Center so that it wouldn't be a burden on each state to kind of be that subject matter expert about rural emergency hospitals, creating one national center that can be that subject matter expert to help hospitals and individual communities by creating kind of broad resources and then more individualized TA. So I'll talk in more detail about that. Providing supplements to the Flex grantees, knowing you are connected in with the hospitals in your state, that the Flex program is already kind of that key support for the critical access hospital. And knowing that you'll be getting questions anyways. So providing you with financial resources to help you get word out to your communities, but you're not going to be the subject matter expert on this. We'll have the National TA Center where you can direct people to for those kind of more in-depth questions that you get. And then also recognizing that with this new model, there's going to be state legislative changes that will have to be made to incorporate the rural emergency hospital model. So we have existing HRSA partners that we fund. So the National Conference of State Legislatures will be tracking all the different bills that are coming through different states so that there's kind of a one-stop shop to see what's happening and then see where their examples are of what's going on in different states. And then the National Association of the State Health Policy will be pulling together focus groups of people who kind of crafted language already in states and come up with kind of best practice and templates for other states to use so they don't have to reinvent the wheel on this. So for the National TA Center, it's ensuring that hospitals and communities have the information that they need to be able to make the determination if it's the best fit for their community to move to this new model, and then also help them as they move into this new model. So, you know, from the process of assessing feasibility, assisting with the application, and then providing support as the new REH will implement their new services. So the TA that we envision will be developing resources that are useful for kind of broad dissemination, getting information out to a broader group of kind of basic info on what the REH is, what might be the factors that would make someone more inclined to be successful in moving to this new model. So that'll be useful, I think, in partnership with the work that you're doing through your Flex supplements, kind of that outreach and education piece. So you're not having to create those all on your own either. And then providing that more in-depth one-on-one assistance with communities who kind of take a first look and say, you know, this might be something that would be useful for my community. Then they'll kind of dig in more on their financials, understand their community health needs, and go through the process to really assess, does it actually make sense when we look at it on paper? And then maybe even apply and start implementing the REH services. So it is kind of a broad range of issues. So the TA Center will be able to provide assistance across financial analysis, workforce and staffing planning, helping figure out referral relationships, looking at service lines, community health needs, and then the impact on other community health systems, such as the emergency medical services systems. So this program, it's a 5-year program. We have it at $2.5 million per year. So there will be one award for the national TA. So applications were just due a couple of weeks ago, and it'll be a September 30th start date. So we hope to have, you know, before then maybe, or by September 30th, that award out for that national TA Center. And now I'll turn it over to Laura to talk about the Flex supplemental piece.
Thanks, Christy. So yeah, as Christy mentioned, we're going to be or you have already, some of you may have already seen the supplemental amount that is going to be added to your Flex Program award to help with this transition. Now, I want to make sure that I clarify something. This funding for you all in your Flex Program is meant for outreach and education. It is not meant for you to become the subject matter experts and you do all of the conversions. Outreach and education are the two key words because we already know Flex programs do that really well. You already have existing networks with your hospitals. You already know, and especially if you're, sometimes the Flex coordinator and the SOAR coordinator are the same person. And if not, you work very closely together, and you can include not only your critical access hospitals, but those small rural 50 beds or less PBS hospitals as well. So this is a really great opportunity for us to get creative, right? We can figure out what it might mean to reach out to hospitals that maybe you haven't reached out to before, and they are eligible for this conversion. So again, it's outreach and education only. And the nitty gritty of the details of what we need in EHB, we can talk about all of this at a later date. You can all talk about it with your project officer when the time comes, but eventually we're going to start this process through what's called a request for information. And that's something that we initiate in each of your grant folders. And we're going to need the same thing like you would need for your carryover requests, right? So that SF424 form, and then Liz, I see your question about the anticipated need. I'll get to that in just a second. So the forms you'll need, the SF424, your budget justification explaining how you're going to break down the money. So the same thing like you normally would in your normal flex budget of staff time and travel time and contracts, how you break that down, and a work plan. Now, these documents will only be needed for the amount for the REH supplement. You do not need to go all the way back to revise your entire flex budget, right? Just for this amount. And that's not going to be due until November 30th. So we have some time to work on all of that. And I do want to make sure that we make this point. So it's almost like it's in two pots of money, the way that they've processed it here on our end. So it's a separate funding line, which means we cannot wrap it into general flex activities. It is separate from your regular flex work plan. If we can go to the next slide, Christy, I'll give a couple of quick examples on what this might mean. And I see Rachel's question has just come in on examples of what it would look like to use that funding. So this could be done in a couple of different ways. And you all can maybe reach out to us and tell us you have different ideas of what we're thinking about, right? So one thing that would be allowable, if you want to hire a contractor to host a webinar, an educational webinar to explain what the REH model is, right? That would be an allowable expense. You can also do this as covering FTEs. It can cover staff time. It can even cover travel time if you want to do site visits regarding these hospitals, right? Now, what would not be allowed is, let's say you as a flex coordinator are going and conducting a regular flex program visit that you would normally be doing, a site visit to your normal critical access hospital, and not talking about the REH model. You cannot pay for that out of your REH bucket of money. You can pay for that out of your regular flex money, but not the REH bucket of money, if that makes sense, okay? So if we go to the next slide, my piece of advice, and then I see some questions in the chat that we can kind of get to in a second. My piece of advice to everybody is to not panic. So just hold on for a second. You know, we're getting questions, it's already been asked in the chat, of what if we don't need the money? Well, we don't know that yet, right? There, as George mentioned in his presentation, the $268,000 that could be an extra monthly payment for your hospital, that was a lot more than a lot of people thought it would be. And so until the rules are finalized, we really don't know how everything is going to play out, and we don't know what's going to happen. So just take a beat and hold on. And even if you want to wait until the National TA Center comes out and they can kind of help put some materials together for you to talk to your hospitals and things like that. But at the very least, some of that money can be used to start the conversations with them, right? And if that money, if the hospitals ultimately come back and say, no, we are not interested in converting, it is not good for our communities, that's fine. We will have a mechanism on our end, and you can see at the very bottom of this slide, ultimately, if the money is not spent, the full amount is not spent, it will be returned back to FORHP. That can be dealt with when the time comes later on. But for right now, just hold off and we can start using this funding to just engage the conversation, right? So there's a lot of common questions like we just talked about. How do I spend my money? What if I don't need the money at all? What if I don't spend all of it? there's things that we're still working on. So there's going to be flexibilities on our end. There will be creativity on your end. But we are going to be coordinating some future webinars with all of you to kind of put some questions together. If you have them, share ideas. And one of the really good examples right now is that you can talk to your project officers. All of the flex notices of award to start your next year for FY22 are dropping like right now. So most of you should have already gotten your NOAs. I think there's only a few that are still being processed by our finance folks. So you're going to be getting an email with your project officer to say, hey, let's set up a phone call. And one of the things they're going to talk to you about is this REH money. So if you have additional questions on what you can use it on, if you have some ideas, if you want to talk about what's allowable, what's not, that's a perfect built-in phone call that will be happening in probably the next 2 to 3 weeks as a one-on-one with your project officer. And I will say Jennifer in Kansas has just shared, and I'll read it in the chat, that they've done a lot in Kansas through the hospital association to lay the groundwork. And she has examples of things flex programs may be able to do and is able to share. So we could probably, Tracy, correct me if I'm wrong, we may be able to share some of that wide with everyone.
Yeah, absolutely. If you want to send that along to TASC, Jennifer, certainly would give you credit, but we could send it out to the flex programs in the listserv or something like that too. And that'd be great. Really great.
Okay, the question, Stephanie, how do you know how much money is allocated to the REH initiatives on the notice of award? Your project officer will go over this in your notice of award call, but I will say it right now. At the bottom of page 2 in your notice of award, it's box 39. The lower number, whatever number is lower, and there's 2 boxes, right? There's one that's going to be your flex amount, and there's one that's a lower amount. That amount is your REH supplement amount. Are there any other questions? Does anybody want to come off mute and talk about ideas of what they may have concerns?
This is Michelle from South Dakota. I just wanted to make up, just let you know that on my NOA that on box 39, I had looked at this last night. I think my CFDA numbers and the dollar amounts are switched. So the 93.241 is the dollar amount for the REH supplement. And the 93.912 is the dollar amount that should be my flex award.
Let me look at your NOA, South Dakota, right?
South Dakota, yes.
Yeah, let me get into your grant folder when we're off of this, and I'll shoot you an email if I can do some research on it. And
okay.
And it'll probably be tomorrow, but I'll send you an email when I look at your NOA.
That's fine. I just wanted to let you know in case they're all like that. You know, I just thought I should bring it to your attention. So thank you.
Okay. Yeah, let me look and see.
Oh, can I ask one more question?
Of
So
course.
these, the funds will be tracked separately. So the REH funds will be tracked as a separate, other than your flex dollars, correct? They'll be tracked in 2 different accounting systems.
Everything, Christy, correct me if I'm wrong, it'll all go back into PMS, right? But just separate funding lines.
Yeah, so it's like 2 streams of funding that are coming into your one account. So from your end, we just need you on paper to clearly identify what funds and activities are for the REH activities versus like everything else will be like a separate work plan and budget for the flex award.
Okay, thank you. Yeah, thank you.
Jennifer, I see your hand raised.
Yeah, so my question is about the time frame for the supplemental. So does it start September 1 and go to August 30 of 2023, or do we have more time?
It goes to 2023, the end of your next grant year, just like your normal flex funding would. If there is a possibility that you're spending some of your money and maybe some of those activities aren't finished yet and you want to carry it into the next year, we can discuss that when the time comes. But it is going through August 31st of 2023.
Thank you.
And I'll say too, like I mentioned at the beginning, we don't know what things are going to look like. So we were just saying, okay, for year 1, this is what makes sense. So it's helpful for us too, to get feedback on what might make sense for flex programs for the next year. Once we have a better idea of what things actually look like, what your conversations with hospitals are kind of informing you about. So we're really excited as you get out and start talking to your hospitals. I know some of you already have been, but just hearing more about kind of what is the conversation. Is there a lot of interest? You know, some states might have a lot more interest than others. there's just so much we don't know right now. So as we learn more, we want to make sure that whatever we do in FY23 kind of aligns with where the needs are once we know more.
Any
Thanks,
other
Christy and
questions?
Laura. I have a question, actually. If you could just repeat it so that it sticks in my mind, is can you share the percentages of the award amounts, like the percent of the proportion of the normal award amount that's being added in for each program?
It is 9% for REH and 8%. No. 9% is a regular increase for flex and 8% for REH.
Okay, cool. Thank you very much.
Oh, and it looks like we may have a few others with the CFDA numbers messed up. So that will be my first project to work on tomorrow morning, and we'll see what's going on.
Okay.
I just had a question. So the program runs from September 30th to August 31st?
That's for the TA center that starts September 30th.
That's what it went so fast. Okay, so this is
Yeah.
for the TA service?
So your regular flex money that you are getting to your flex account, this REH supplement, starts on September 1st, just like your regular flex award. And that's for you to do outreach and education to your hospitals. If any of them need to be referred over to the TA center, or if you need to speak to the TA center, however that would work, that TA center will not start until September 30th.
Okay, now thank you for making that clarification.
Yeah, and that's
Okay.
why I wanted to make sure to give you until November 30th to get your work plans in and budgets, because we know like there's just so little information right now. There's just not
Mhm.
a lot that you'd be able to put together. So between now and November 30th, we'll definitely be having a lot more conversations with you. Appreciate those states like Jennifer and Kansas who are already doing things and can share those resources that we can all learn from. And then once that National TA Center comes on board, kind of October, November, they'll be able to provide more information as well that can help you.
Great, thank you so much.
What else? Other questions that people have? Feel free to use the chat or unmute, raise your hand, whatever works for you. So Sarah Young put in the chat that based on the usual calendar year, she anticipates that the Center for Medicare and Medicaid Services will be publishing the REH final rules on or before November 1st. So that would be fantastic. Well before January 1st as well. So that would be really lovely, I think. So
feel free to put questions in the chat or ask. There's no bad question. There's so many questions at this point. I know sometimes it's hard to even know where to start, but
I have a question to put out there and I see Lisa's hand raised and people can think about this, or maybe Lisa, you want to respond too, but for those that have been through the phase of the heavy critical access hospital conversions, so this was back in the earlier 2000s too, any advice you have to share with those that haven't been through this sort of process before about just kind of things to consider, or questions that you should be asking, or processes to maybe have in your program? I know that we're kind of getting a little bit ahead of yourselves too, but just some lessons that you have to share from that, I think would be helpful for others to hear about too. So just to put that out there, if anybody has something that comes to mind. And Lisa, go ahead. What's your question?
Hi, can you hear me?
Yes, we can.
Okay, great. How quickly will it take, is it required to have this technical assistance center up and running? If they get their funding fairly soon, we all know that it can take a while to hire staff and make sure, and get everything together, but we are really going to need them right away if we're going to be able to accomplish anything in the time frame.
yeah. Yeah, and in the notice of funding opportunity, you can see how it's laid out for the National TA Center. Like, okay, you're getting your award September 30th. Hospitals are eligible starting January 1, 2023. So I think, anyone applying for this will have built their plan out based on that, knowing it's going to be hitting the ground running, knowing you might be coming into this and there might not be final rules from CMS. So it's like, going to be a very busy few months.
Right. So they know that they're going to be really needing to be up and running ASAP.
Mhm.
Okay, great. Thank you.
We did have a question come in that might be a Sarah Young or even a George question. If tribal 638 hospitals are eligible?
I don't know the answer to that.
I think
Oh, I would say like IHS critical access hospitals would be eligible, but not the tribal. Is that right? Sarah?
I think actually even some of the non-CA IHS and tribal hospitals might be eligible. Again, the qualifying criteria is, were you recognized by Medicare as a hospital on the date the legislation passed, and are you in a qualifying rural area? So a tribal hospital that checked all those boxes would potentially be eligible. I think that is another area that it would be really helpful to CMS for folks to put in public comments and say, this is not clear. I recommend you make this decision and that you clarify it in the following ways. And the fact that we all have so many questions about this, I'm sure for folks who went through through the development of critical access hospital status back beginning in 1997, there were lots of these kind of questions at the start of that also, but they've been worked out in the last 20 years. So it's going to take time to work out some of these questions.
And Sarah, one answer to your question came in from Oklahoma that yes, they've been getting questions on almost all of the site visits, and there is a hospital interested that they would never have expected.
And there was a question about the state licensure status, and I know you talked about the assistance, Christy, coming from the national or the Congress of state legislatures. We've heard of 4 states that have passed legislation. That was South Dakota, Kansas, Nebraska, and Texas.
There's a question about who covers the cost for the analysis about whether a facility would want to or could consider the REH conversion, about whether or not where that comes out of. And the answer to that is that comes out of the funding that's allocated for the Rural Emergency Hospital TA Center. So it's not expected to be funded by the facility itself to do that assessment, nor is it expected by your flex program to cover that amount. So if they choose to move into action about that and move to the REH model, then there's certainly expenses that the facility needs to cover to convert, but they would continue to get technical support then from the REH TA Center as well.
This is Lisa. Can I ask another question? I forgot to put my hand
Please,
down
yeah.
before, but I'll do that now. So in terms of looking at the changes that need to happen within the individual states, will there be conversations with, let's say, ASTHO or other groups, or the state, the state health directors that can help us educate our individual states, especially states like Pennsylvania's that are going to be looking at a potential major shift in our state leadership after the election? And so I'm just wondering, if there's anything like through NCSL or any of those groups that anyone has thought about to try and educate policymakers.
Yeah, the funding that we have is specific to kind of drafting the new licensure requirements at the state level, not specific to kind of the advocacy piece of it. So I think that's something that we can figure out, does that make sense as part of the TA center, or like a separate funds that we can put into other HRSA projects?
And Christy, a question just came in the chat that I'm going to confirm this answer with you from Idaho. Can flex funds be used to help the critical access hospital do the financial analysis, like a sub-grant? So we know the cost of that should come from the TA center, but if there is a need, can flex funds support that, or that's all on the TA center?
Well, what we're trying to do with the TA center funds is, we know flex funds are so tight. So there are funds available to help communities determine if the REH model is feasible. So, you know, I don't think that wouldn't fall. But I think that would fall under like a flex allowable activity, but I know there's so much potentially if it's just doing kind of a broad financial analysis. But are there other things that you could use that flex money for if there's funding available through the REHTA?
And one more question, what happens to the rural health clinics that are licensed as a department of a hospital?
Sarah?
That sounds like one for me. So that's another area where the proposed rules could probably be clearer. The legislation does allow for provider-based RHCs that were provider-based to the hospital that converts to an REH to continue being paid as provider-based RHCs. So that's my expectation about how that they would keep operating the same way and keep getting paid the same way. The proposed regulation text is not very clear or explicit about how that would happen. So there's an opportunity to for CMS to do a better job of clarifying that process in the final rule. And it is something that if you or your stakeholders have questions about, that'd be a really good thing to submit public comments about. And I see Carolyn put the link in the chat.
Any other questions? And I'd like to encourage everybody, if questions do come up as you're kind of processing this information, and certainly as the time moves on, or TASC, you can send them to TASC. We might be able to answer them now, or we'll work with FORHP or whomever it may be to get you the right answers, so that you can kind of keep moving forward and making plans as information is released about this project. Because we certainly do want to support the flex programs in your role with what's been tasked with you with supporting your hospitals and converting potentially to this status.
We did just get another question, and I don't know if we have the answer to this, but do we know if there's any implication that the conversion of a CA to an REH might have on the EMS system? George is nodding yes.
Yeah, I'm writing some articles with the rural emergency doc, who has very great concerns about this and the ability of the EMS system to adapt to this new model. For one thing, there are going to be a lot more transfers placed on the local EMS than there has been in the past. Patients that used to be admitted as inpatients to the facility will be transferred now to a trauma center or some other facility. So that's going to have an impact on their transfer volume. As we all know, EMS in many parts of the country is not well organized. It's not physician-led. There's just a lot of problems that may get exacerbated if the proper arrangements are not made. So I don't want to be a naysayer, but I think it will have definite implications for EMS, and there are going to have to be some fairly substantial improvements in some areas if they want to make this model work.
And George, one more. Oh, sorry, go ahead.
I'm just going to comment. I just totally agree, George. It has significant implications for these smaller ambulance services. If they only have one rig and they have to transfer out, that's going to mean they're going to be uncovered with an ambulance. So we've got to keep that in mind. It's a serious concern. Thanks.
George, one more question came in wondering if an REH can have their own level 4 designation.
That's a good question. I don't know the answer to that either.
Is that a Sarah question?
I don't know that I can answer that either. I think that's probably going to be very state dependent, because in a lot of cases, I mean, my understanding is some states have level 4 trauma center designations and some states don't. And what a state would qualify as that, I don't want to say, I would not exactly lower level, but less complex trauma center designation is going to be very much up to states, how they classify that. It's not, there's not a Medicare designation for level 4 trauma centers, so that's going to be something that's state to state.
Sarah, would it be common for a level 4 trauma center to have no inpatient beds?
I don't know. You know, not that I am aware of, but there's a lot of variation in health facility licensing across the country. So I wouldn't want to say it's never happens either. Some of the states that have a stronger existing infrastructure around freestanding EDs may do some trauma center designation with some of their freestanding EDs. I just don't know.
Good questions, everybody. So we're about at the end of the time here. So I want to certainly thank actually all 4 people that were on screen right now, Sarah and George and Christy and Laura, for your time and sharing your expertise and what we do know now and what we don't know and what we'll follow up on as well. So we'll close out with our polling questions. So there's the same 2 questions as before about your level of knowledge and if we helped at all today to improve some of your understanding. So I'll ask Patricia to post those now.
And while everyone's filling those out, I'll just make one quick note. I received 4 messages on states that may have the CFDA numbers backwards. If there's anyone else who may have that or has a question, shoot me an email and I'll look at it first thing tomorrow.
Great, thanks, Laura.
Yep, Idaho, I've got you.
Yeah, that's great. So there's 4 polling questions there, 2 about the content today, or 2 about the knowledge today, 1 about whether or not you'd like to implement something in your program, and then a final 1 about your overall satisfaction. So take a minute to complete that. And while you're doing that, I just wanted to share a couple updates about some upcoming events too to have on your radar. There is the last TASC 90 webinar of the year. So that's for the State Flex programs as well. That's on August 17th at 2 p.m. Central Time. And that will be on the State Flex Program Staff Sustainability Guide and Toolkit that will be released before then, and hopefully will be a wonderful aid to any workforce challenges that you might be experiencing within your state program. So look for that calendar event. If you haven't had it already, we'll be sending out another notice as we get closer to the date, but that's on August 17th. On August 29th, there is the final of all final National Rural HIT Coalition webinars. And that's been a coalition that's been going on since 2006. This call will focus on public health infrastructure modernization. So we encourage you to join that as well. And then the last kind of webinar event for this program year for the State Flex programs is there's a telehealth webinar on August 30th about alternative origination sites for rural telehealth. So please take your time and tune into that as well. All those calls start at 2 p.m. Central. If you have any comments, questions, or concerns, or things we can help you out with, please don't hesitate to reach out to us at TASC. It's task@ruralcenter.org. And thanks for the great conversation today. I know we're all trying to figure this out together, and we appreciate your active engagement and questions that kind of get all of our wheels turning. So thank you very much, and I hope you have a great afternoon and evening.